it's so much more powerful if you can go to your healthcare provider and say, look, I have 3, 4, 6 months of data here. I've missed work X number of times. I haven't been able to attend lectures X number of times. I've vomited 6 times this month because of pain. I took X amount of ibuprofen and it maybe reduced my pain from 10 to 6 or 10 to 8, or maybe not at all, right? That's so much more powerful than just going into the appointment and saying, I have really painful periods.
Today's episode is all about the connection between endometriosis and IBS. Endometriosis affects 1 in 10 women, yet many still go years without answers. To help me break this all down is Cindy Dabrowska, registered dietitian who specializes in endometriosis and fertility nutrition. As an endo warrior herself, she made it her mission to support others walking the same path. Let's get into it.
Hello, Cindy, and welcome to the show.
Haley, thanks for having me.
Yeah, I've been really excited to have this conversation. I think we've been talking about doing something for probably like a couple years now. And I know I've had a lot of clients with IBS who have been actually later diagnosed as having endometriosis. So I think it's a very, very important conversation to have. And I'm excited to dive deeper and really hear your side of the picture and get your expertise on endometriosis.
Yeah, there's certainly a big overlap for sure between IBS and endo. So it's a great topic to cover.
Yeah. So just to start off, I'll let you tell us more about yourself, really who you help, where you're located, and sort of share more about Cindy behind Endometriosis Dietitian.
Sure. So my name is Cindy Dabrowska. I'm a registered dietitian specializing in endometriosis and fertility. I had endometriosis myself, so that's kind of the bridge there between why I got into this space. And a lot of my personal experience is what led me to work with women who have endometriosis and infertility or subfertility as a result of endometriosis. You know, I've been through the ringer as somebody with endometriosis, all those like typical treatments that are thrown your way, you know, hormonal birth control, hormonal suppressants, surgery. And I unfortunately didn't have the best of luck with these options. And so, you know, I thought to myself, there has to be another way. And we have nutrition guidelines for so many other chronic inflammatory conditions. So I just thought to myself, you know, maybe I can apply some nutrition, lifestyle, maybe supplement strategies to help with the pain. And that's been a really effective strategy for me. And that took me a really long time to discover, you know, over two years of researching and trial and error. And so I really wanted to bring that to the endometriosis population so people can start to kind of tease apart what may help and what may not help from the sort of holistic, natural, functional medicine space. I do. So like I said, I work exclusively with people who have endometriosis and infertility as a result of that endometriosis. And I'm in Ontario, Canada. And yeah, it's just a big passion of mine, obviously, because of the overlap with my personal experience.
Mm-hmm. And yeah, it's definitely like a very common condition too. I know you've had your practice now for about 6 years.
Yeah, 2019. I was launched the online platform. It's crazy how fast it flies.
And I think it like exploded pretty quickly, right, in terms of your online audience and following. And I know you've had a pretty busy private practice, so obviously speaks to the need and the demand for more, I guess, call it like holistic or integrative strategies for endometriosis, and people seeking that, you know, high touch evidence based support that they can't get from maybe the, you know, conventional medical healthcare system.
Yeah, I do agree. And I think, you know, I always say like it's great for me in terms of my practice for sure, but it's also heartbreaking to see how big the need is in this space. And I think that largely stems from, okay, your options are, and they're not even good options in my opinion. I mean, they can be helpful, don't get me wrong. I mean, I don't want to go down a rabbit hole with this, but you know, you're presented with hormone therapies. Maybe you're somebody with endo who has tried these and didn't have a good reaction. Your other option is surgery, but maybe you're waiting a year for that or 18 months for that. Sometimes it's a ridiculous recommendation, but sometimes pregnancy, you know, is suggested as an intervention. And you might not be somebody who's in that stage of life where this is something that's top of mind for you. And so I think it's a natural, segue into wanting to explore the natural side, right? And we do have a lot of literature. We have a lot of research that shows various vitamins, minerals, various types of diets, and the foundations, as I like to call them, like a good sleep and exercise, and how they have a very positive, profound effect on symptoms of endometriosis. So, yes, I would agree that there is a big need, and I think it kind of stems from the lack of options offered, right, through traditional sort of Western medicine.
Definitely. And I know here in Canada, it's even just getting harder and harder to, get testing done, blood work, get referred to a specialist. The wait times are becoming longer, and that just means more people are sort of suffering with their symptoms and, not really able to maybe even get that endometriosis diagnosis for a long time too, which we'll go into more. I guess just for you personally, I mean, you can share as much as you feel comfortable, but did it take you a long time to sort of discover that endometriosis was at the heart of the symptoms you were experiencing? Did that happen like from a young age, or what sort of your timeline look like?
Yeah.
Personal story.
Yeah, so endo is so interesting, because like you can be somebody like me who is symptomatic from your very first period ever, and I can definitely give you a little bit more context and detail there. Or you can be somebody who, didn't start becoming symptomatic until after like fertility treatments or in your older years or after surgery or something like that, right? Like it's so different for every single person. There's also the silent endometriosis where you're not presenting with those characteristic pain symptoms, but usually the first symptom there is infertility, right? You haven't been able to become pregnant and you're looking for an answer as to why that is. But yeah, for me, 12 years of age, first period ever, extremely debilitating, like not a good way to, to be introduced to womanhood and menstruation. And yeah, so I remember actually vividly, like I guess I would have been in elementary school at the time, and I was in the office. They were calling my mom to come pick me up because I was in pain. And yeah, it was just, yeah. So from 12 years of age, it was just debilitating, unpredictable symptoms. I don't know exactly, Lee, but I want to say like I probably didn't hear about the word endometriosis until I was maybe like 18, 19 years old. That's probably when I kind of first was introduced to it. And then I was diagnosed in 2018. So 15 years of living with those symptoms, not knowing, what was going on. At that point, I had suspected endometriosis because I knew what it was. I had started dabbling in those natural lifestyle strategies before then. So I had already found a way to manage my symptoms, but I was formally diagnosed through the surgery in 2018. I was newly married. My husband was there with me when I had my surgery. He actually recorded a video of the surgeon explaining where they found the endo. And although I didn't get a lot of symptom relief from the surgery, unfortunately, it was just really satisfying to know that there was something causing these symptoms all these years. So, yeah, that's my story. I'm somebody like very early on, I was symptomatic. And sorry, my husband was leaving. Yeah, very symptomatic. But I think it's important to note that it's different. It's different for so many women, right? You could be like me and you could be symptomatic very, very early on, and those symptoms could become extremely more painful, more debilitating, more uncomfortable. Or you could be somebody who doesn't have pain for a big chunk of your early teenage or young adult years, and then you suddenly do become symptomatic. Maybe it's stress induced, maybe it's some kind of nervous system dysfunction component, maybe it's abdominal injury, maybe it's childbirth. And so, yeah, endo is definitely not something I wish on anybody. It's extremely complex and confusing, but yeah, that's my introduction to endometriosis in my personal life.
Wow. Wow. And I guess along that, like that 15 years, were you told it was anything else? Like, did you receive any sort of inaccurate diagnosis or sort of given a reason for your symptoms or?
Yeah, a lot of just like it's normal, you're a woman, so not necessarily a diagnosis, but just kind of brushing off the symptoms. IBS, I have had a lot of like various testing done. Like I had colonoscopies done at a very young age. I've had, gosh, more ultrasounds that I can count. Um, but I am somebody actually like you see a lot of content online where people are saying, I was diagnosed with this long list of things, IBS, Crohn's, uh, some kind of autoimmune condition. In my case, maybe IBS and just kind of brushing it off and not really giving me much of a diagnosis. That's my personal experience.
Mm-hmm. And just sort of telling you to take pain medication, rest, and yeah, I don't know if you were told to go on birth control.
I did. Yeah, I was. I'm very transparent about this. I did take birth control for a big part of my teenage years and young adult life up until about, 21, 22 or so. That's a whole other story, but basically it just kind of stopped working for me. Like I started getting strange symptoms in response to the birth control, and my doctor's response was to put me on a stronger one, and something about that didn't really feel right to me. And that's when I started to explore the sort of natural holistic side. But yes, I was, and I'm super transparent about this. Like it definitely did give me a huge amount of my quality of life back. Like it definitely allowed me to be more flexible. I mean, I was a student at the time. I went into university, and so it definitely gave me a lot of that quality of life back for sure.
Mm-hmm. For a certain amount of time, and then the symptoms
Yeah,
came back. Just curious.
yeah. And there's a whole story also with when I transitioned off, and that was probably when my symptoms were the worst, actually, when I came off the pill, and I spent 2 years trying to rebound from that. Yeah, it was like mental health side effects. It was physical side effects like spotting, extreme pain, like to the point where I would vomit and faint from pain. I would lose control of my body. I would turn white as a ghost, but then seconds later I would burn up. So, yeah, really scary when that happens.
Mhm.
Really scary when
Yeah,
that
can
happens.
yeah, with birth control pill, it can be it's yeah, it can be interesting just in terms of the symptoms that it can help, but then also the symptoms that it can end up with. But yeah, that is a whole nother conversation for
Um,
another day, maybe. In your experience, like what led you to getting that diagnosis? Like, did you advocate for referral to a specialist or like a certain test, or how did you finally get that diagnosis?
Yeah. So when I heard that term endometriosis and I was convinced I had it, it was literally I looked up endometriosis specialists near me. I essentially demanded a referral to one that I found online that I knew was taking new patients. I saw the surgeon within like a few weeks. And then within 3 months of our initial meeting, I was scheduled for surgery. So I recognize that I'm very fortunate because a lot of people connect with the surgeon and then they have to wait 6 months, 12 months, 18 months. Some people have to travel to different countries to get the surgery. They have to travel across, this like the states. And it's very expensive in different parts of the world. So I recognize that I'm very fortunate that 3 months for meeting with the surgeon, I was able to have the surgery. And yeah, it was basically just advocacy. I told the doctor what I wanted. I definitely got pushed back, but I mean, at the end of the day, this is my healthcare. And it's funny because when I told her that, it turned out that I had endometriosis and this is what was causing my symptoms all these years, she basically responded by saying, "Oh, well, we knew that something was wrong." Okay, well, then why didn't you push? Why didn't you suggest a referral years ago? You know what I mean? And now, especially, like, sorry to go off on a little bit of a tangent here, but now that we know that it's really important to catch endometriosis in your earlier years if you're symptomatic because it has such profound effects on fertility. And so it can make a huge difference to a young person's life to be able to diagnose this early and support them in like fertility preservation or, get them on the right types of interventions. And so, it's not something to just like brush under the table and not give much attention to. Like it is important that young people, if they're symptomatic, if they're suspicious that they may have endometriosis, get a diagnosis. And I know that one of your questions, Lee, was around diagnosis. So like I don't know if that's something you want to bring back up after or talk about it now, but we do have advancements in how to diagnose endometriosis. So it's not as complicated as it once was. So we don't really have excuses for waiting 15 years or 20 or 25 years in the case of some people to get a diagnosis. But that's how I went about getting the diagnosis.
Yeah, that makes sense. I guess you are also fortunate in the sense that you're a healthcare practitioner yourself, and because of your education, you obviously have a higher health and nutrition literacy. So you're able to sort of look into the information and the evidence on it and then be able to, clearly advocate for yourself. Whereas people who maybe don't have that background, it can be even more challenging just not knowing what to ask for. And then sometimes people can sort of fall into, I forget like what the term is, but sort of just seeing their doctor as having like, the most important or the most valid sort of reasoning or opinion, just sort of just giving into whatever their doctor says and not really feeling comfortable or feeling like they're able to push back or advocate.
Yeah.
So yeah, I can see how, will go on for a long time that maybe people don't get the answers that they need to. I think just to lay the foundation, for some listening, they may, have endometriosis and probably familiar with what it actually is, although I'm sure you get people who are diagnosed with it and don't even know how to explain it or what's going on. But in simple terms, explain exactly what endometriosis actually is.
Yeah, for sure. So endo is a chronic inflammatory condition, primarily of immune dysfunction. And I can explain what that means in a moment. But this is when tissue that's similar but not identical to the endometrium, so the tissue that lines the uterus, grows. Basically, we found it on every organ of the body at this point. It does respond to the cyclical, hormonal shifts throughout the cycle. And so these lesions do bleed, or this tissue, however you want to refer to it, it does bleed. But because it's not within the uterus, it's not like exiting the body as menstrual blood, right? And so it bleeds into the abdomen or the thoracic cavity or wherever it's located on the bladder, et cetera. And then that can, bind organs together. That can cause extreme debilitating pain. It definitely contributes to infertility or subfertility. It could affect organ function, right? If you have it on the ureters or if it punctures your bowel deep enough. And so that is endometriosis.
Wow. So it affects a lot of different systems in the body then, not just sort of central to the female reproductive system. Like it affects other organs and
Right.
symptoms in all different areas, which sort of, I guess, then makes sense as to why it maybe would not be diagnosed as early. But can you explain sort of how someone would get to a endometriosis diagnosis?
Yeah. So you're not wrong when you say that. Yep, it impacts multiple different systems throughout the body, and therefore it could be mistaken for other conditions. Absolutely. I mean, it could be mistaken for IBS. It often is mistaken for IBS because upwards of 90% of people with endometriosis have like some kind of digestive symptoms, bloating, constipation, diarrhea. I think for so long, it's been kind of normal, unfortunately. I mean, it shouldn't be normal, but I think it's been kind of normal to just brush off pain related to menstruation. And so, that's another kind of overlap as to why the diagnosis is often delayed. So, okay, let me take it back to the initial question. What does it take to get a diagnosis? So there are a few ways that you can get diagnosed with endometriosis. I do think that it's important that you have sort of the right team to get you there. And so if you are suspicious that you have endometriosis, and we can talk about the symptoms in a moment to maybe make that a little bit clearer, but it is important that you have like the right team, people who can recognize that this may be endometriosis or request the right referrals. Because if you're talking or connecting with somebody who's not well versed in endometriosis or kind of gaslights you or, belittles your pain or I don't know, something extreme, like doesn't think endometriosis is a thing or something like that, obviously you need to kind of be in the right hands to get that diagnosis. But it could be as simple as just, looking for an endometriosis specialist near you, like wherever you are located geographically, and, assessing to see, do they take patients right now, and just requesting a referral to that professional. That's like the best way to start the process. I think this is like more of an appropriate answer to some of your other questions, but I would definitely suggest that if you are suspicious that you may have endometriosis, definitely start tracking, right? Track the cyclical nature of your symptoms, when they're getting bad. Are you experiencing some of the other symptoms of endometriosis, like pain with intercourse, pain with passing stools or urination? are your symptoms around menstruation or these high pain phases of your cycle, like maybe ovulation, so debilitating that it's affecting your ability to do activities of daily living? Are you vomiting, fainting? Are you losing control of your body? Is your pain untouched by over-the-counter pain relieving medications? Are you passing a lot of blood, clots? Do you have extremely low energy? Is there, digestive symptoms, constipation, diarrhea? Are your bowels bouncing around, right? Like, are you going from one extreme to the next? These are just some symptoms, right? Of course, it extends into infertility. It extends into like the mental health side, bladder pain and pressure, pain with urination, things like this. Also, if you've got like a very hard, distended abdomen, right? That like not necessarily bloating. And I know a lot of people have a hard time kind of differentiating bloating between abdominal swelling or inflammation. But if it's just like always very swollen, always very inflamed, that could be also an indicator. But yeah, back to charting the symptoms. So chart, right? Because it's so much more powerful if you can go to your healthcare provider and say, look, I have 3, 4, 6 months of data here. I've missed work X number of times. I haven't been able to attend lectures X number of times. I've vomited 6 times this month because of pain. I took X amount of ibuprofen and it maybe reduced my pain from 10 to 6 or 10 to 8 or maybe not at all, right? That's so much more powerful than just going into the appointment and saying I have really painful periods. It's unfortunate that we have to try so hard, but it's going to be much, much harder for the healthcare provider to dismiss. And it is their obligation, if you are presenting with these, quite debilitating symptoms, to offer you something or offer you a referral or medication or something. So up until recently, the gold standard for diagnosis is laparoscopy with excision. So this is a type of surgery where small incisions are made and then the endometriosis lesions are cut out essentially from the root. And then they're biopsied to confirm, if it is in fact endometriosis lesions or if it's something like scar tissue or something like that. And so it's been the gold standard for a really long time because of that biopsy portion. Like in my case, for example, when I had excision done, they biopsied all the lesions, small parts of the lesions that they excise. And on my left abdominal wall, it was actually scar tissue, not endometriosis, right? Whereas endometriosis is found on my bladder and on my bowels and on my cervix. And so those places were endometriosis, but then there was that one spot of scar tissue, right? So they want to be able to differentiate that. But now there's these newer technologies, right? Like if you have deep infiltrating endometriosis where it's penetrating the surface quite a bit deeper than superficial, which is just kind of right on the surface, this can often be seen in through using advanced ultrasound. So I do want to be very aware that like a regular ultrasound and somebody who's not trained in reading these ultrasounds to identify endometriosis might not be able to communicate that diagnosis to you. But if this is somebody who's well-versed in advanced ultrasound, they know what to look for. They know the way that the tissue behaves when fluid is added. You can absolutely receive a diagnosis. And it's very accurate for deep infiltrating endometriosis. You can also see deep infiltrating endometriosis on scans like MRI. You can see large endometriomas, which are cystic lesions. It's a more advanced form of the disease. So you can see those through ultrasound and MRI. I guess the last thing I'll say too is like, if it's not showing up on ultrasound or MRI, it doesn't mean it's not there. It might mean that you have a superficial form of endometriosis, and that doesn't mean that it's less severe. It doesn't mean that it's less likely to cause you less pain. Like you can have a very early stage of endometriosis and still be experiencing extremely debilitating symptoms. So the how aggressive it is or whether it's superficial doesn't necessarily dictate how much pain or the severity of your symptoms that you're experiencing. But yeah, if it doesn't present on ultrasound or MRI, it doesn't mean that it's ruling it out, right? It doesn't mean that, oh, it's not showing up, so you don't have it. You would then still need to pursue a surgery to get that formal confirmation, right? Because surgery really would be like the best way to rule out superficial. Have I answered your question, Lee, or did I just go off and answer some other questions?
I think that was really helpful. And I guess if someone has the MRI or the ultrasound and it doesn't show that they have endometriosis, but they have that data from symptom tracking,
Yeah.
sort of, highlights that symptoms of endometriosis, then would you suggest someone still sort of pushes or advocates for themselves to do the surgery? That way they can fully rule it out, even if the first test said, they may not have it.
Yeah, definitely. And it's also a treatment option, right? So a lot of people do experience symptom improvements with excision. Like it's very hit or miss. You might have a symptom improvement, you might not, like in my case, but it is also a treatment, right? It does restore fertility in many cases. It does help with pain. It can change the hormonal profile. So it is still a treatment, right? So just getting a diagnosis through ultrasound or MRI, that's just like one part of the battle, right? You still need to then actually pursue some kind of treatment.
Yeah. And when you say endometriosis specialist, is that like a specific designation, like a gynecologist, or you're referring to like a nurse practitioner, or
Yeah.
what would that look like?
Yeah, that's a good question. I mean, I think from like the traditional sense of like an endo specialized doctor, it would be an OBGYN who specializes in endometriosis, or a gynecologist that specializes in endometriosis.
Yeah. Is that common, or is that hard to find?
It's very hard to find. Very hard to find. Yeah. Yeah.
I guess even where we are, like, well, I know you're not quite in Toronto, but are there many here, or like a select few?
There are a few. There are a few. I mean, there's not as many as we would like to have, of course, right? There's like Dr. Leonardi out of McMaster. I think there is one doctor working out of Humber River, but I'm not 100% positive if he's endo specialized. I know that there's somebody in Ottawa as well. Don't quote me on the name, but I think it's Dr. Singh. I could be wrong, but there are a handful. I mean, like think about the population of Ontario, of Toronto, like just these big, like Toronto, Ottawa, like three names, like that's not enough, right? That's not enough. But I'm sure there's more, but there's not enough, I guess, is my answer to that question. Yeah.
And I guess with all that in mind, like, do they know what causes endometriosis, or is it just sort of theories for now, or sort of thoughts as to what can contribute to it developing?
Yeah. Right now, I mean, the short answer is we don't know. It's a lot of theories, right? So some theories have to do with retrograde menstruation, so the backflow of the menstrual blood through the fallopian tubes back into the pelvis. There are theories around genetics and how genetics play a role. I would say that the genetic theory is very alive and well. Like, you are 6 times more likely to have endometriosis if some immediate family member has it, like your mom or your sister or your aunt. And so I think that that's pretty solid. But I mean, that still doesn't explain the cause. There's, theories around environmental toxins and dioxins and their role to play in endometriosis establishing and starting and then growing in the body. There's various theories around, I don't even know what to call it, but it's like a certain type of, I want to call it a stem cell, that they theorize is traveling through the lymph even pre-birth. And that's explaining why endometriosis can be found in any part of the body. So there are a couple of theories, but yeah, we don't really know for sure the cause. Maybe some combination of those things.
Yeah, a large genetic contribution.
Yeah, there's also there's the bacterial one, which recently got a lot of attention on social media and in the media, because there was this study which really wasn't even that strong around a certain type of bacteria, Fusobacterium, being connected to endometriosis. But that has been a theory as to why endometriosis may establish. But yeah, there's just theories right now, unfortunately.
Yeah, what's the idea with that? The bacteria contributing?
Just that it's more common in people with endometriosis, and that it can be part of the reason why it establishes and grows. We tend to have more of it, right? We tend to have more of it in the various microbiomes throughout the body. Mm-hmm. That's basically it. And then in the study, they treated mice with antibiotics to get rid of it. And then they noticed that the endometriosis lesions kind of almost started to disappear. They started to get better. But this is very controlled too, right? It's very controlled. So we don't know we don't know what the application of that study would be in real human women who have endometriosis. You know what I
Yeah.
mean?
It was an animal study.
It was in mice. Yeah,
Those poor mice.
I know.
And what conditions do you often see overlapping? No.
Oh my gosh, a lot, because endo is so multifaceted, right? There's like the chronic inflammation component, which could predispose you to other chronic inflammatory conditions, like even things like elevated cholesterol, high blood pressure, diabetes, these types of things. There's the mental health component. We know that people with endo tend to produce less serotonin. And then that can lead to more anxiety, depression, those types of diagnoses. Lots of other chronic pain conditions overlap as well. So I think I mentioned like the chronic inflammation, but migraines, interstitial cystitis, painful bladder syndrome. There's the GI side too, right? A lot of IBS, a lot of this kind of overlaps with like the autoimmune realm, right? Because there is also this immune dysfunction component in endometriosis where the immune cells don't function as well as they should. And so we know that there is a huge increased likelihood that you'll develop some kind of autoimmune condition if you're somebody with endometriosis. So it could be celiac, it could be inflammatory bowel disease. It could be Hashimoto's, but there is an overlap there as well, and a genetic overlap as well. There's the fertility related conditions, so PCOS, adenomyosis, which is the sister condition of endometriosis. So lots from the side of like inflammation, immune dysfunction, chronic pain conditions, the autoimmune piece. And yeah, and I mentioned the mental health component as well. So yeah, unfortunately, a lot.
Yeah. Wow. I guess in the case of IBS, I know there's been several studies on it, but a 2022 systematic review meta-analysis that looked at the overlap between endometriosis and IBS, and I think they found that people with endo have about a threefold risk of also having or developing IBS. I think with the way that like IBS is diagnosed, like the Rome 4 criteria should be used. It's not always used, but that's sort of been evolving. So in terms of that being like a set diagnosis in that patients, we're not entirely sure, but the idea there is that like IBS is common alongside endometriosis, which I'll just explain. I know many listening know what IBS is, but it's considered like chronic functional gut disorder, typically with persistent abdominal pain, gas, bloating, and then sort of diarrhea, constipation, or like alternating episodes of both. Typically considered like a gut-brain disorder, but I think based on more recent research, I see it more as like a microbiome disorder just because of the role of the gut microbiome. And then even there's like an autoimmune component that we're learning more about with IBS. So I guess why do you think that maybe those conditions are often
Overlapping
together? Yeah.
Yeah. Well, I mean, you alluded to one of those causes or reasons, which is the microbiome, the dysbiosis there. There's also other studies just in the endometriosis population showing that women with endometriosis, tend to have more dysbiosis in the gut microbiome with a predisposition towards more pro-inflammatory species, E. coli, Prevotella. There's some other ones as well. So there's that, right? There's the visceral hypersensitivity component as well. All of that inflammation just making those internal organs significantly more sensitive. And that, includes the digestive, the organs responsible for digestion. There's also a lot of, with endometriosis, it's this chronic inflammatory condition, right? Like often when I'm doing like testing with patients or we're trying to tease apart like what hallmarks apply to you, there's a big like mental health component, the gut brain axis component, right? Because I mean, you're living with a chronic inflammatory condition. That's just going to be a stressor in and of itself, right? And then most people, the average person will have a ton of other stress, right? Like I always tell people, I don't think that it's normal to be completely, well, maybe I shouldn't use the word normal, but I think it's common for everybody to have some degree of stress, right? And we live in a stressful world. There's a lot going on in the world. but it's important that we know how to manage it, right? And when one of the things that's contributing to that stress is this chronic illness that's so unpredictable, and it's like manifesting in symptoms that you can't make sense of, and they're so unpredictable and they're changing from year to year. I mean, that's going to be a huge stressor, not just mentally, but even physically. And so I think that that has a big role to play too in terms of that gut brain axis, right? Because we know stress is a huge driver of digestive symptoms, of IBS type symptoms. And so I think that that's probably the reason, right? That the gut brain axis, the inflammation component. One thing I didn't mention is the hormonal component too, right? We know that endo is estrogen, it's an estrogen dependent condition. Now, not everybody will present with elevated estrogen in blood work or like urine tests or however you're testing the hormones. But, we know that estrogen can thicken bile. It can affect digestion as well, and so it can be a source of inflammation. And so again, there's that spillover of inflammation into the digestive symptoms and the effects on visceral hypersensitivity. And so I think that there's a few reasons to like a few reasons. That's another one of the reasons too, right? And so yeah, I would say visceral hypersensitivity, the inflammation, the gut dysbiosis that we know is very common in the endo population, the inflammation component. I think those are all reasons why these two diagnoses overlap so much.
Yeah, I wonder too, because I do have clients with IBS that don't have the visceral hypersensitivity symptoms, although it is really common, like I think up to like 70%. So and just to explain it, that visceral hypersensitivity is like an altered sensation to pain, or sort of a abnormal pain response. Specifically in IBS, like the nerve receptors in the gut may detect pain or send a message of pain to the brain to things that may not normally cause pain, like a little bit of normal stretching or gas production in the bowels, or maybe sort of respond a lot more strongly so to things like FODMAPs or fiber or versions. But I guess with sort of like looking at what may contribute to visceral hypersensitivity, I think a lot of the common reasons are potentially the gut microbiome imbalance, sort of causing low-grade inflammation in the gut. I think even like adverse early childhood events and trauma, like lifestyle changes, maybe mental health, sleep issues, even different nutrient deficiencies, even thoughts around like iron and copper and blood flow and all that. And I think you sort of mentioned as some of those being maybe, connected to contributors of endometriosis development too. So you can kind of see, one will contribute to the other, and then also, sort of cause both.
Yeah.
I guess with endo too, like you mentioned, like you have sort of tissue growing on other parts of the body, and you mentioned like potentially on the bowels as well. So if someone has that excess tissue like growing and pressing on the bowels, would someone get an IBS diagnosis because of that? Or is that just considered maybe they'll have GI symptoms as a result of the endo, but it not technically being IBS?
Yeah, I mean, if it's somebody who's not really investigating the root of those symptoms, they might just end up with an IBS diagnosis, right? Which I would argue is very dangerous, because if this is endo that's rapidly progressing, it's deep infiltrating, you can literally have endometriosis puncture the bowel, right? And that becomes a lot more dangerous. So yeah, it's possible that if you have symptoms, IBS-like symptoms because of endometriosis on the bowel, it's possible that you might just get an IBS diagnosis. But if it's somebody who's digging a little bit deeper, they might dig to see, is there what is the root of these symptoms? And if they find that endometriosis on the bowel, then I don't know. I don't know if that would still be IBS, or if I would imagine that would probably be an endometriosis diagnosis. And I would be really curious to know if that individual notices improvements in their digestive symptoms when they have it excised. And anecdotally in my practice, I've had people report that those symptoms do improve with excision surgery. I don't know if I answered your question.
Yeah, no, I think it's hard to tease out. I guess with IBS, like technically the thought is that you're having those symptoms and there's no sort of like abnormalities in the, digestive tract of the large or small bowel. But if someone did have those like lesions or, excess tissue pushing on the bowel, then you could sort of say that it's the endo causing the symptoms and they may not have IBS, but I guess if
Yeah.
they were to have it removed and then they still have, the typical IBS symptoms, then they may still have both. But
Yeah.
definitely important to get get a proper diagnosis so that you can actually treat what's going on and not just assume.
Yeah. I was going to add too, like, anecdotally, like this is not typically the way you would see digestive symptoms present, but I've had people who've had like cyclical digestive symptoms, right? And so that's kind of something that you might want to dig a little bit deeper into, right? Like I wouldn't expect somebody to test positive for something like small intestinal bacterial overgrowth if their symptoms are not consistent all the time, right? Like if you're experiencing painful, persistent bloating, if you're chronically constipated, have diarrhea, if there's some kind of triggering event that kind of snowballed into these symptoms, then yeah, that would line up a little bit more to me. I mean, obviously, I would still want to investigate that, but I wouldn't think twice about having somebody do, and I don't know what your position, Lee, is on like SIBO testing and that sort of thing, but like I would probably not, jump to testing if the symptoms are not consistent. But I have seen in practice people have cyclical symptoms and test positive. So yeah, endo is very tricky. I think it can complicate a lot of these symptoms. And in this particular person's case, she did actually get a lot of relief from her symptoms with treatment. So it's very fascinating.
Definitely. There's a lot of levels and layers to it.
Definitely.
Physically and metaphorically.
Yeah, for sure.
In terms of the connection between like gut microbiome, gut health, and endo, I guess how do you work with that in your practice, whether someone does have IBS or does not have it overlapping with endo?
I always like to, like, if somebody presents with digestive symptoms, I always like to investigate that. I don't like to just kind of chalk it up to, I mean, for the longest time, people were saying, IBS is sort of like a blanket term. If somebody's actively having symptoms, like they're having diarrhea every day or they're chronically constipated, these are things that have massive implications for the way that you live with endo, right? If you're having diarrhea every day, you're losing a lot of beneficial nutrition that your body can be using to fight inflammation in your body or support hormone production or whatever it might be, right? So I don't really want to just chalk that up to IBS and not make an effort to try and improve that if we can. Same thing with constipation, right? Constipation, we at least this is my understanding, it will create more of a kind of pro-inflammatory state in the gut, right? And so not only does the gut become an additional source of inflammation for you as somebody with endometriosis, but there are other implications of that, right? We know the gut is a major site of serotonin synthesis. We're already depleted in serotonin as people living with chronic inflammation. And so, that can have effects on mental health, on energy, on mood, on sleep quality, and all those things matter, I would argue a little bit more than the average person because you're already dealing with chronic inflammation. You're already dealing with this immune dysfunction component. So we want to be extra on top of these foundational pieces like good sleep and your ability to move your body and eliminate. We also get estrogen cycling back into the body from the gut, right? So if you're not able to, have that estrogen exit through your stools, then that's, there's the potential that it will cycle back. And we know that endo is estrogen dependent. We don't really want a lot of that excess estrogen floating around in the body. This was a big part of my personal journey with endometriosis. My symptoms were terrible when I was constipated and eating McDonald's 3 times a day when I was at USP in I don't know, when was that, 2015 or whatever. Terrible, like terrible, terrible, terrible. Constipation, must be resolved, if you have endometriosis. Sometimes it's a little bit trickier to resolve, but it's important for those reasons. And what was the last thing I was going to say? I mean, we synthesize some vitamins in the gut, and these are vitamins that are especially important for the nervous system. They're very important for estrogen elimination, for supporting the liver. So, I have no idea if I'm answering your question, but I guess the answer is I do want to address it. So how I go about addressing it, it depends on what the symptoms are. Sometimes it's not sometimes the first step is not, okay, let's, go plan of attack, let's get you on like 16 different types of fiber and this 50 billion probiotics. Sometimes it's just, okay, let's assess the diet and lifestyle. Let's see if we can boost up the fiber content. Let's complement the nutrition in your diet with maybe a supplement like a multi or a prenatal, because you're losing a lot of nutrition in the case of diarrhea. For constipation, again, like foundations, hydration, movement, and fiber. Can we improve these things first? If that's not working, if I'm assessing your chart and you're getting that 30 grams of fiber in, that 32, 35 grams of fiber, because I do like to see it a little bit higher in the endometriosis population, and the hydration is, consistent with that amount of fiber, let's move into, maybe trying some ginger or a science-backed probiotic strain for constipation, right? Like, let's kind of try these things in sequence. But yeah, I definitely don't want to leave them just not addressing them. Like I want to try and intervene on that. And that's actually typically my first place that I start, right? Because the gut is so central to all of these other things. So yeah, that's the first place I start.
Yeah. And it also affects how you feel. Like you said.
Oh yeah.
Losing a lot of stool, then you're losing nutrients. You could become dehydrated, losing electrolytes. And then on the other hand, being constipated is it's not fun.
Yeah.
About when things are going to clear out of you and having that hard belly, it can be so uncomfortable.
Yeah, and like I can't even tell you how many people report to me and say like, I am scared to go anywhere because I don't know when I'm going to have a bowel movement. And like with endo, passing a bowel movement can be so much scarier than for the average person, right? Like some people black out from pain. They get such sharp stabbing pains in the rectum. It can be scary. Like if you have to travel and these things are happening, it's uncomfortable. But I know that that's very common with IBS patients as well.
I guess the takeaway from what you said about the gut connection is that endo is so like unique to each person. And I think sort of understanding like what are the drivers of their symptoms and their sort of unique profile of that, and then using that to address the treatment and the management strategies, which I guess looks different probably from person to person.
Yeah.
Yeah. And it's similar in IBS too. Like part of it is understanding what their subtype is and then sort of getting to the root of what's driving their symptoms too. Is it the dysbiosis? Is it more around the gut-brain connection, motility issues, and sort of that? Treatment may not look the same from person to person, and not everyone just needs to do the low FODMAP diet. And take your probiotics.
What are the subtypes? Are those the things you were just listing off there, like the motility issues?
Technically IBS is considered to have 4 different subtypes. So there's IBS-D, diarrhea dominant.
Oh, those ones. Okay.
Yeah. IBS-C, constipation, IBS mix. So you get alternating both. And then there's also IBS-U, where they actually may have normal bowel movements, but then they get the symptoms like pain and bloating and gas.
How is that last one treated or managed?
I find with that one, actually, they tend to have, another part of the picture going on. Sometimes even
mental health
or IMO. Yeah, mental
health. Oh, yeah. I see.
Typically another condition, but
I see. Okay.
Yeah. I usually see with IBS that they have IBS, but they usually have something else going on too. So
yeah. I see a lot of that, but I didn't know that there was like a formal IBS designation for that. It's good.
Yeah. So they still like have daily type 3-4 bowel movements on the Bristol chart, but then they get the symptoms of IBS and they've had testing done, nothing else going on, no sort of, abnormalities in the gut, and IBS-U. I know.
Good. That's interesting.
One last thing around the gut health, I guess, how does GALT or GALT play a role in
Yeah, the immune connection. So, I mean, the gut is our largest immune organ. It houses 70-80% of our immune system. And so, if the gut is dysbiotic, if it's inflamed, if it's unhappy, if we're lacking a lot of anti-inflammatory bacteria, that's going to have a spillover effect into your immune system, right? The way your immune system functions. I actually posted something on socials that got a lot of hate in the last couple of weeks about this connection. But, when you really dig into it, and you understand that having a healthy anti-inflammatory environment in the gut equates to better functioning T cells, B cells, like, and then if you dig deeper, you go one step deeper in the research and go and you learn how these various immune cells are dysfunctional with endometriosis and how having a healthy gut directly corresponds with better functioning of these immune cells. And then if you add into that, complicated collection of information that I just said, if you add in that component, that understanding that endo is a condition of immune dysfunction, it's that the fact that these cells do not function optimally is the reason why these endometriosis lesions are able to establish and develop a blood supply and grow. I would absolutely go so far as to say that that has a profound effect on you being able to control how endometriosis behaves in your body. And that is something that I will continue to, to say, because I think it's true. And I think you have a good understanding of the research and understanding of the human body and how these things are connected. I think it's not difficult to acknowledge that there is that connection there, but that's what it is. It's the connection, that overlap between the gut and the immune system.
Yeah, for sure. I guess we're learning that, the gut microbiome plays a role in so many conditions: diabetes, Parkinson's disease, food allergies. Yeah, so many things. So how can we dismiss it as not having it?
Yeah. This is completely anecdotal, but when I do some functional testing, I do see that, and I do want to acknowledge that the tests we have available are not perfect. They are flawed. The microbiome changes with every meal that we consume. But when I see really important species under detectable limits like Akkermansia, this very often will correspond with the most severe symptoms that I see in practice, right? So that's anecdotal. I'm sure there is research to that. I'll find it, but it just goes to show, right, just how profound that overlap is.
Yeah, definitely. I guess for the clients that you work with, how long do you find it typically takes for them to see improvements in their symptoms? What's the average? Or
yeah, I wish I could be like, yeah, it's 3 months for every single person. It's such a mixed bag. I mean, some people, it could be within a few weeks, right, that they can start to see their bloat come down, their following period be better in terms of pain symptoms, their bleeding patterns change, whatever their objective is. It could be a few weeks. It could be 3 months. For some people, they don't see improvements with natural or holistic strategies. And that's just the reality of endometriosis, right? Some people, really need the surgery. Some people do really well with hormone therapies. And some people do really well with the holistic side. So I wish I could say, as a little plug to my services, that it works for everybody, but it doesn't. It's just the reality, right? It just doesn't. And I always say, if you have the resources, if you have the capacity, if you have access to support in every single one of these realms, like if you can get surgery, if you can, work with a pelvic floor physio, if you can work with a dietitian, I think you're going to have the best luck with that sort of comprehensive approach. But it depends. I mean, just like surgery didn't work for me and doesn't work for many others, that might be the only thing that works for other people in the endometriosis space. It's very complicated and confusing.
yeah, I guess, can you just highlight what are the sort of the typical medical treatment routes for endo?
Yeah.
That look like? What would a doctor suggest?
Yeah. So it would be pain medication. So ibuprofen, or it could be a more intense pain relieving medication. It could be morphine. It could be opioids, that type of thing. Hormonal birth control. So combo hormonal birth controls, synthetic progesterone and synthetic estrogen. The progestin only pill has become very, very popular just because it's one that, I mean, all of these have side effects, but this is one that seems to do quite a bit better. There is quite a bit of positive research coming out about it. So progestin only, and that's things like Vyzan, Dynagest, Mirena IUD. So Mirena is a whole kind of other, because it's an IUD, so it's a different type of hormone therapy, but it is a progestin only as well. They're not being used as much anymore, but aromatase inhibitors like letrozole, Clomid, and then there's like the gonadotropin releasing hormone agonists and antagonists, which are like Orilissa, Lupron. Actually, in the research and in the guidelines, like the clinical practice guidelines for doctors working in this space or medical professionals working in this space, a lot of these big institutions that I guess publish the guidelines. Like I know the one in the UK has changed recently. They're actually moving away from recommending the gonadotropin releasing hormone agonists and antagonists because the side effects are just crazy, right? They basically, you go from having healthy levels of estrogen to postmenopausal, like within a few days or within a week. And so you get a lot of the like hot flashes, the bone pain, the mood shifts, like really low thoughts. And so, and they're not really even finding them to be super effective. So, yeah, lots changing in that space too, but those are sort of the traditional like medical management options. And then, of course, there's surgery. And I mean, I wouldn't even go so far as to say it's a treatment for endometriosis because it's absolutely not. But hysterectomy, right, having the uterus removed, it's a mixed bag. Some people report, you know, it's absolutely given them their life back and their quality of life. Some people continue to have symptoms after a hysterectomy, but it's not really a treatment for endometriosis. Like you don't need your uterus in order for endometriosis to grow, right? You don't. But in the research, when the ovaries were preserved, they did see, I think it was like a 60% likelihood of recurrence. It is less with when the ovaries are removed, but then you have to think about the symptoms and the side effects of that, right? When you're having your ovaries removed, this is a major site of the largest site of estrogen production. Progesterone, well, technically the progesterone's produced through the corpus luteum, but yeah, that drastically changes the hormonal profile. And then you have to think about what are the implications of no longer making those hormones. So, yeah, I wouldn't go so far as to say that that's a treatment option, but some people do pursue hysterectomy. Yeah.
Mm-hmm. Yeah. Okay. And then I guess what advice would you have for someone with the IBS diagnosis, but maybe has suspected endometriosis? I think you, yeah, maybe alluded to it before, but for those listening, what would be your advice to them?
So somebody has IBS symptoms, but also suspects endo, right? That's the question.
Yeah. Mm-hmm. Maybe their IBS isn't getting better. Sort of the typical IBS strategies.
Yeah. It's tricky. Yeah, it's tricky. I would say like absolutely endo could be a part of that symptom picture for sure. So if you're suspecting endo, if you have other symptoms of endometriosis, I would definitely kind of get the ball rolling on maybe getting a diagnosis, getting scanned for that. But yeah, I mean, yeah, sorry, Lee, I'm doing a terrible job answering this question. Like if endo is part of that symptom picture, then certainly, you know, you're going to want to explore like some kind of management of the endo, and that might help for sure. That can help. Depending on where the endo is, how deep infiltrating it is, you know, having surgery, having excision surgery, you know, can help. Sometimes when I have patients who have a lot of uncomfortable digestive symptoms with endo, I like to recommend things like frequency specific microcurrent or visceral manipulation or like a self massage or like just being extra on top of those like manual therapies so we can try and get the tissue to kind of be a little bit more mobile. But yeah, if endo is involved, I mean, you're definitely going to want to seek out support for that. But I think whether it's IBS, whether it's endo, whether it's both, I think the foundations are always really, really, really important here. If you're somebody who's kind of gone through the ringer, maybe the foundations are not new to you, and this is not information that's new to you, but protecting the sleep, you eating the well-structured meals, spaced, you know, a decent amount apart, like not grazing, right? 1 hour, 2 hours. This is the recommendations I make, but 3.5 to 4 hours in between meals. You know, hydrating really well, moving your body. These are, oh, sorry, that was really loud. The foundations of like good health, right? Sleep well, manage stress as best as you can, because this will help both of these two conditions, right? Whichever one it is that's affecting the symptoms or contributing to the symptoms. But yeah, ultimately, if endo is at the heart of that, then maybe some of those manual therapies, definitely seeking out a referral for a diagnosis would be step one.
Yeah. Okay. And like you said, tracking symptoms to get those data points, and then looking for an endo specialist and advocate.
Yeah. Yeah. I think tracking the symptoms is extremely powerful because, maybe you're somebody who just has the digestive symptoms, but you don't have a lot of the characteristic pain symptoms of endometriosis. When you're getting those symptoms and how they're presenting and, whether they're directly tied to your cycle, like that's very helpful information to have, right? Like if these things are only happening cyclically around this time, that's obviously indicating that there's hormonal involvement. Maybe there's inflammation stemming from the hormonal shifts in that time of your cycle. And that can really help, navigate uh, who you get referred to, the timeliness of that referral, and these types of things. So, yeah, I think especially important when IBS and endo symptoms overlap.
Yeah. Actually, that going a little off track from that, but that made me think of something that I sometimes get stuck with is when someone is has an IUD and they only bleed every 3 months and they're not tracking. How do
Mm-hmm.
we know if their symptoms are cyclical?
Yeah.
If they don't get that traditional bleed, that's where it gets a little tricky. What are your thoughts?
Yeah. So, no two people are the same when they are taking hormone therapies. I have clients who take hormone therapies and they still get cyclical symptoms, like literally cyclical symptoms to the point where I think we can probably even see this reflected in blood work because they're so obvious, the symptoms, that I think that we might be able to like track some data there. But if you're somebody who, they're not cyclical in nature at all, um, I guess I guess I would look at other biomarkers. I'd look to see, like, are you getting any kind of discharge? Are you getting any other kind of symptoms that are consistent with endo that are not um, maybe cyclical in nature? Like, are you inflamed? I'd also maybe look to see if, like, we know that these hormone therapies will affect different parts of the body differently. Like, they can affect the liver, they can make you mildly insulin resistant, they can contribute to a bit of blood sugar dysregulation, they can affect the thyroid depending on the medication. So I might do a deep dive there to see if there's any patterns consistent with that. And if we intervene on those areas, like maybe if we're seeing mild insulin resistance or something like that, and we work on the diet, maybe we add in magnesium or something to help with insulin resistance, and if the symptoms improve, that might be kind of one uh, indirect way of gauging whether it could be something like endo. I mean, I'm coming up with ideas here that ultimately, like, it could be so much more simple if you're just scanned or if you seek out the surgery for endometriosis, right? Like, I also don't want to encourage people to wait if they're suspicious of endo, because the faster you can get that diagnosis, the faster you can kind of start to work on your health and get answers. But it is a good question. Yeah, sometimes people present with the symptoms, even if they're on hormone therapies. Sometimes you can rely on other biomarkers. Not everybody with endo skips ovulation on these hormone therapies. Some people will continue to ovulate. And so you can lean into like cervical mucus or temperature shifts. There are temperature shifts and cervical mucus patterns that you can look for to determine whether there's cervical inflammation, whether you may be producing high levels of estrogen, which might be consistent with endo, whether your temperatures are low, which might indicate progesterone resistance in the luteal phase. So it's all very complicated stuff, but I guess it depends on the individual. But yeah, I don't want to discourage people from waiting to get a scan or to get assessed for endometriosis. So that would be the first step. I would still suggest doing that.
Yeah, for sure. I think that's probably really helpful for people listening. We covered a lot today, a lot of great details, and I'm sure a lot listening had some light bulb moments. I guess any final thoughts or anything that we didn't touch on that you want to add for our discussion today?
So, I mean, I guess one thing would be Some hormone therapies, if you are somebody with endometriosis, have interesting ingredients that can exacerbate digestive symptoms. A lot of birth control pills contain sugar alcohols, can contain lactose. So especially if you're noticing the symptoms kind of change around the start of a certain hormone therapy or medication, maybe just look at the ingredient list and make sure there's nothing in there that you know you're reactive to. I have literally had so many clients who are like, okay, I'm having these digestive issues. And I'm like, okay, how long have you been on the birth control? I've been on the birth control for 6 years. Okay, it has mannitol, it has lactose. Can we switch it? Can we try and switch it for a different one that maybe doesn't have these? Or would you be willing to come off of it temporarily? Symptoms completely go away. Or sometimes the birth control is a barrier to them being able to clear something like intestinal methanogen overgrowth. So that's one thing, just because there's a big overlap there, right? Like if you have endo, the first thing you're likely going to be suggested is some kind of hormone therapy. The big thing which we talked about at length is the tracking, right? Track as much as you can. I know it's annoying. And as people with endo, we don't want to be super hyper aware of our symptoms because we're already super hyper aware. But this is really important data for you to have. It's going to be so much harder for you to be dismissed if you can say, look how sick I was. Look how many pain medications I took. Look how many days off work or school I had to take off. So track the symptoms. And then, if you're suspicious of endometriosis, just seek out an endo specialist as soon as you can so you can get confirmation and you can intervene and get some direction on your plan of attack, basically, as soon as possible. So those would be my final thoughts there. And follow my Instagram and send me any DMs if you have questions.
Yeah, that's my final question. So where can those listening or watching on YouTube get in touch with you? Do you have any free resources, anything that you want to share? And I'll include the links below in the episode.
Sure. Yeah. So I'm probably most active on Instagram, and my handle there is endo.fertility.dietitian with 2 T's, no C. I don't know who spells dietitian with C's. Do you? Is it like an American thing? Anyway.
Anyone who's not a dietitian, typically.
Okay, there you go. There you go. So yeah, that's my handle there. I'm also on TikTok, same handle, endo.fertility.dietitian. I have a Pinterest, I have a YouTube, the YouTube channel's the Endo Fertility Space channel. And yeah, my website, I've got blogs on there. And I'm quite responsive. I mean, I may or may not respond to you right away if you send me a DM on like a random weekday in the middle of the day, but I am usually quite responsive in DMs if you send me a question. So that's where you can find me, and I look forward to connecting with you.
Yeah, awesome. Well, thank you so much, Cindy. This has been a really great conversation, and we look forward to hearing some comments, maybe getting some questions about what we chatted about. And I'm sure there'll be a few people listening that this definitely relates to their experience. So
Well, yeah, thanks for having me, Lee.